In this video, we are going to discuss about the clinical features of a bomb blast. So, the nature of the injury may produce multiplicity of the external signs and making detection of important internal injury very challenging. So, here you can see the severity of the external injuries. It's often seen with explosive blast may or may not indicate associated severe internal injury. A clinical examination is difficult and requires a high degree of experience and suspicion, as well as early use of imaging. So various manifestations are given in a systematic way. So we are going to discuss initially about the cardiovascular system, cardiopulmonary, and later on other organs too. So in the cardiopulmonary, the lung is very susceptible to the primary blast injury because it is mainly filled with a gas. So pulmonary barotrauma is most common fatal primary blast injury and most common critical injury in people close to the blast center. The pressure differentials across the alveolar capillary interface can cause disruption, hemorrhage, pulmonary contusion, pneumothorax, hemothorax, pneumomediastinum, subcutaneous emphysema. Air embolism is another well-recognized consequence of blast lung injury and is probably one of the major factors leading to cardiac dysfunction and immediate death after blast wave exposure. Although it is usually difficult to diagnose specifically, the resulting neurologic symptoms caused by air embolism must be differentiated from the direct effects of the CNS trauma. Pulmonary fat embolism is a finding of clinical importance in survivors of blast trauma because it can lead to development of acute respiratory distress syndrome and significantly affects clinical outcomes. In general, managing a blast lung injury is similar to caring for pulmonary contusion and acute respiratory distress syndrome, except that early recognition of the syndrome may be complicated by initially benign symptoms, especially in the context of hectic mass casualty incident situations. Hypoxia is an almost universal finding. Monitoring of the respiratory rate, room air pulse oximetry, as well as serial chest radiograph may be needed. Fluid administration should ensure tissue perfusion without volume overload. The decision to institute mechanical ventilation must be made carefully because it entails the assignment of what may be scarce critical care unit beds and ventilators, and also exposes the patient to the potential complication of the pulmonary barotrauma, commonly seen with the fragile lungs associated with the blast lung syndrome. So we need to keep tidal volume low, so we must opt for low tidal volume strategy. That is 6 to 7 ml per kg of ideal body weight to limit the peak inspiratory pressure and minimize ventilator-induced barotrauma. And neuromuscular paralysis can be instituted, and early institution of pressure-limited ventilation, that is plateau pressure less than 30 centimeter water, with the lowest pressure compatible with the adequate ventilation may be the best strategy. Inverse IE ratio, that is in inspiratory-expiratory ventilation, may be useful. Permissive hypercapnia is acceptable depending on cerebral perfusion pressure or increased intracranial pressure. Aggressive methods of oxygenation, such as extracorporeal membrane oxygenation or intravascular oxygenation, may be necessary within hours of injury. There are no definitive guidelines for observation, admission, or discharge of patients with possible blast lung injury. Admit patients requiring complex management to an intensive care unit. In general, asymptomatic patients with normal chest radiograph and normal room air pulse oximetry may be considered for discharge after 4 to 6 hours of observation, as long as there is no clinical deterioration. And survivors of this type of injury typically have no long-term pulmonary complaints, and most have normal physical examination and chest radiographs and normal lung function tests. So we need to look after these patients and discharge after 6 hours of the normal vital hemodynamical stability and other things. So coming to the next part, that is organ affected, that is ears. The tympanic membrane ruptures at 1 to 8 pascals per pressure per square inch of dynamic overpressure Dislodgement of the ophicals may also occur. Patients with an isolated tympanic membrane perforation and no other immediately identified injury should have a chest radiograph ordered but do not automatically require an extended period of observation. Conversely, intact tympanic membrane do not imply absence of serious injury, and the use of perforation of the tympanic membrane as an indicator of the primary blast injury missed up to 50% of those suffering a primary blast injury to the lung. Clinical judgment is necessary, and limited observation is reasonable for patients with intact tympanic membranes. Experience from the Boston Marathon bombing suggests that blast-related otologic injuries were a major source of continued morbidity and required extended follow-up. Now, coming to the abdomen injuries from explosion may be occult, and reported injuries are low, but missed injuries may carry significant morbidity due to delayed intestinal perforation and necrosis. A review of literature on the abdominal trauma from the primary blast injury reveals an incidence of 1 to 3 to 33%, and terminal ileum and cecum were the most commonly injured areas. So the serial clinical examinations, serial imaging as needed, and 24 to 48 hour observation are indicated whenever the suspicion arises. Air is a poor conductor of the blast wave energy. Thus, patients who were subjected to enough energy to damage abdominal organs probably were situated near the explosive device. So there have been case reports of the pneumoperitoneum without a vessel trauma. So if the patient is suspected to have been near the explosive device, CT scan of the abdomen and pelvis might be considered. Now, coming to the brain injury, the conflicts of the global war on terror in Iraq and Afghanistan have resulted in over 250,000 diagnosed cases of traumatic brain injury. Mild traumatic brain injury has been labeled as signature injury of the war in the Iraq. Penetrating shrapnel is the most common cause of brain injury, but there may be a component of the blast overpressure induced compromise of the blood-brain barrier and cerebral blood vessels. The clinical examination may be misleading for penetrating injuries. Shrapnel or low velocity missiles often producing a small entry wound in the survivors. Small entry wounds may be missed under the hair, and evidence for traumatic brain injury may initially be benign or masked by the anesthesia as the patient undergoes treatment for other life-threatening injuries. Neuroimaging is an important early diagnostic tool in these circumstances. So, if you can see here in this CT scan of a 17-year-old female patient in a terrorist bomb blast, the girl walked into the ED unassisted and was triaged green, but deteriorated after 30 minutes. Fortunately, the clinical deterioration was noted. She underwent emergency CT and extensive neurological intervention. So you can see here in the CT scan there is a small foci, and with that there are artifacts around the solid object. Okay, so this is so after extraction by the neurosurgical team, so there was a 1 centimeter metal ball bearing, and it was extracted, and prolonged rehabilitation was later required for the residual brain injury damage. Okay, so coming to the vascular injuries, small entry wounds from the shrapnel may mask the severe vascular injuries. Compartment syndrome may develop and difficult to diagnose, especially in patients receiving anesthesia. Carefully assess and document pulses and pressure and perfusion in affected limbs. Observe for delayed presentation of the compartment syndrome and measure compartment pressure if any signs or symptoms develop. Early angiography and intervention are indicated if pulses are lost. So if there is an exsanguination from the wounds, it is likely to be most commonly encountered life-threatening finding. Military experience has shown that hemorrhage is most common cause of preventable death in penetrating trauma. Whether venous or arterial blood loss from multiple wounds, internal and external, may cause hypovolemic shock. Quickly control external bleeding with direct pressure. Apply tourniquets for extremity hemorrhage whenever blood loss cannot be controlled with the direct pressure, or if the resources required to maintain direct pressure are insufficient during treatment or transportation. Tourniquets have been successfully used for up to 6 hours in the battlefield situations. Angiographic vascular occlusion is an attractive treatment option if the time and staff are available. victims of blast mass casualty incidents may require massive amounts of blood and blood products. Coming to the ocular injury. So the eye injuries from a blast wave may cause shearing damage to the orbit, but ocular injuries are from a combination of primary and secondary processes. So ocular injuries include lid brow laceration, conjunctival lacerations, open globe injuries, orbital fractures, retinal detachment, retained intraocular foreign body, lens dislocation, vitreous hemorrhage, retinal tears, and retinal detachments. So you name it, there are there in the ocular injuries in case of blast injuries, apart from post-injury infections due to minor injuries too. So eye examination is needed for all moderate to severely injured blast victims, and a poor initial visual acuity is not a guarantee of a poor final result. So coming to the diagnosis, in the ED, order diagnostic imaging judiciously in a mass casualty injury incident because there is a resource restraint, and we need to triage the patients who require most and benefit most out of the mass casualty. So priorities of our care are airway management, treatment of tension pneumothorax and fluid and blood resuscitation. Visualization of the metallic object on a single plane radiograph is often inadequate for thorough evaluation, but it can direct a treatment team on the need for urgent surgery or for the for the additional imaging. Plain chest radiographs and ultrasonography and fast examination are most rapid studies that can be done, that used to evaluate for life-threatening injuries, and we need to order lab tests sparingly. Thank you very much for watching this video.